Yeah, ladies and gentlemen, on behalf of the European APL study group, I'm proud to present a short overview on the study results of the Apollo trial. The Apollo trial was a randomized phase 3 study comparing arsenic trioxide combined with ATRA and 2 shots of idarubicin versus the standard ATRA-based together with a lot of intensive chemotherapy in patients with newly diagnosed high-risk acute promyelocytic leukemia. The latter is a very rare, or you may say orphan disease. Roughly in Germany we have 200 to 300 newly diagnosed patients per year, so very rare disease. And 10 years ago there was a pivotal European trial showing for the first time that a subtype of APL with a leukocyte count of less than 10,000 can be cured by a chemotherapy-free regimen, so-called ATRA plus arsenic trioxide. And taken actually these study results into further development, we use the same backbone of ATRA plus arsenic trioxide supplemented with 2 shots of idarubicin now in high-risk APL. High-risk APL is an even more super orphan disease, so it's very rare. And only 1/3 of APL patients actually are high-risk APL, defined by a white blood cell count at diagnosis of more than 10,000. These patients have also a high risk of complications, bleeding and thrombosis, especially during the early phase of therapy. And we called the trial Apollo trial because we believed to make it and to fly to the moon with this study. So this was an open-label, prospective, multi-center, multinational phase 3 trial, academic trial with only limited funding by the pharmaceutical industry because Teva provided the study drug, arsenic trioxide, in 143 study sites in the European Union and in 6 countries. And what we did, we randomized patients into 2 arms, as you can see here, the non-chemotherapy backbone plus 2 shots of idarubicin at the very beginning versus the ATRA chemotherapy regimen. And to make a long story very short, study had a little recruitment issues because of COVID and other things, so therefore the study was terminated before full accrual had been achieved. But still, after evaluating all the events, the study met the primary endpoint with patients in the chemotherapy-free arm. ATO actually had a 2-year event-free survival of 88% versus 70% in the chemotherapy arm. This was mainly due to a higher incidence of molecular and hematological relapses and also in the chemotherapy arm, and also a higher incidence of molecular resistance after the consolidation. So to conclude, we believe that first-line therapy with ATRA and arsenic trioxide with 2 initial doses of idarubicin results in superior event-free survival compared to conventional chemotherapy in patients with high-risk APL. These were the first results, but we believe that the trial as it stands now may support already now the implementation of this regimen as a new standard of care in all patients with high-risk APL. Thank you very much.